Ever walked into an emergency department? It can feel like absolute chaos, right? Alarms are blaring, people are rushing everywhere, and life or death decisions are being made in a split second. But here's the thing. Behind all that seeming chaos, there's a powerful logic, a system designed to do one thing and one thing only: save lives. Today, we're going to pull back that curtain and see how it all works. It all boils down to this one question. When someone is critically ill or injured, the clock starts ticking immediately. What a nurse does, what they see in that very first minute can change absolutely everything. So, to really get this, let's follow a patient. This is a 32-year-old guy who fell while working on his roof. He's brought in by the paramedics, and he's completely unresponsive. His femur is actually protruding through the skin. He was found in a large pool of blood. His blood pressure is dangerously low, and his heart is just racing. His situation is, well, it's about as critical as it gets. And he's far from alone. Look at this number. Over 130 million. That's how many patients visit an emergency department in the United States every single year. That staggering volume is what leads to overcrowding, and it's precisely why a system is so absolutely essential. You can't just have a first-come, first-served system. You have to have a way to find the sickest person in a very crowded room. And that brings us to the very first and maybe the most critical step: triage. It's really an art form. It's the process of sorting, of figuring out in just a few seconds who needs help right now and who can safely wait. The core idea is actually pretty simple. Treat the life-threatening problems first. A triage nurse makes a lightning-fast assessment of a patient's condition or their acuity to prioritize their care. It's how they create order from the moment someone walks through the door. And they don't just guess. They use a standardized system called the Emergency Severity Index, or ESI for short. It's a 5-level scale. ESI 1, that's an immediate, life-threatening situation. ESI 2 is high risk, they need to be seen within 10 minutes. And it goes all the way down to ESI 5, which is a stable patient who doesn't really need any special resources. And just look at how clear these distinctions are. Someone in cardiac arrest, that's an ESI 1, no debate. Someone with chest pain is an ESI 2. It goes all the way down to, say, a simple cut at ESI 4, or even a prescription refill at ESI 5. So our roofer, unresponsive with massive bleeding, he is a textbook ESI 1. He's not even going to see the waiting room. He's going straight back. Once he's wheeled into the resuscitation bay, the next phase begins instantly. It's called the primary survey. The goal here is brutally efficient. Identify and treat the most immediate threats to his life. Find what's killing him and fix it. Right now. Now, to do this under immense pressure, they rely on a mental checklist. A simple mnemonic: ABCDEFG. And listen, this isn't just a memory aid, it's a powerful cognitive tool. It forces focus in a chaotic scene, it reduces the mental load, and it ensures that in the heat of the moment, nothing critical gets missed. But hold on, there's a crucial first step. Before you even get to A, B, and C, there's another, bigger C: catastrophic hemorrhage. The thinking here has evolved. We now recognize that you can have a perfect airway, but it doesn't matter one bit if the patient has no blood left to carry oxygen. For our patient, who is found in a large pool of blood, stopping that external bleeding is priority 0. Okay, with that major bleeding controlled, now they move to the classic ABCs. A is for airway. Is it open? Is it clear? A blocked airway can cause death in minutes, and it's the reason for nearly all immediate trauma deaths. B is for breathing. Is the patient actually moving air in and out of their lungs? And C is for circulation. Do they have a pulse? Is their blood pressure strong enough to get blood to their vital organ? Once those immediate life threats are managed and the patient is stabilized, the team can finally take a quick breath and move on to the secondary survey. This is where they zoom out from the immediate crisis to get the full, complete picture of all the patient's injuries. And this process is a literal head-to-toe assessment. The nurses and doctors methodically examine the head, the chest, abdomen, pelvis, all 4 extremities. They even carefully log roll the patient to check their back. They are hunting for every single injury, not just the most obvious one. At the very same time, they're gathering history using another handy mnemonic: sample. They're asking the patient, or in our guy's case, the paramedics, about symptoms, allergies, medications, past medical history, their last meal, and the events leading up to the injury. Each piece is another vital clue in the puzzle.
So this logical, step-by-step approach, it's the absolute core of trauma care. But what's so fascinating is that these same principles of rapid assessment and prioritization are just as critical when dealing with a huge range of other crises, like, say, environmental emergencies.
Let's take heat-related illness. A nurse has to spot the subtle but absolutely critical differences between heat exhaustion and heat stroke. In heat exhaustion, the patient is sweating profusely, but in heat stroke, which is a true medical emergency, the body's entire temperature regulation system fails. Their skin becomes hot and dry. Recognizing that one single difference can be the key to saving a patient's life.
And the same idea applies to cold emergencies. Nurses have to be prepared for the entire spectrum of injury, from the blistering of a superficial frostbite all the way to deep tissue death or necrosis, which can ultimately require amputation. The assessment and the treatment for each stage are completely different.
So whether it's a fall from a roof, a case of heat stroke, or severe frostbite, we keep seeing the same pattern emerge. Beneath the surface of every single emergency response, there is a clear and deliberate logic at work. And really, in the end, everything we've talked about, the triage systems, the survey mnemonics, all those detailed assessments, it is all designed to achieve this one single purpose: to recognize what can kill the patient and stop it. It really is a process of finding the signal in the noise. It's how emergency nurses can take a situation that feels like pure pandemonium and, step by step, impose a logical framework on it, turning that chaos into a clear path forward for the patient. It's an incredible combination of deep knowledge, rigorous training, and the sheer mental fortitude to stay focused when the stakes are literally life and death. It really makes you wonder, what does it take to think that clearly when everything is on the line?